This is the Startup Still Say podcast. Thank you for tuning in. Do us a favor, like, subscribe on YouTube or LinkedIn, and be sure to give us your feedback. Hope you enjoy this episode.
Hello, everyone. This is Anthony Prakash, your host for Startup Still Say. Here we are with another brand new episode, and I'm super excited today to bring to you a couple of my friends. We were colleagues or partners in crime a couple of years earlier, but we are all members of a Flutter community right now. And I'm excited to bring to you their story, their mission and vision for something super important in the healthcare world, both in the US as well as the entire world that they're trying to solve. And their company is called MayJuun. So Dr. John Manning here is the CEO of MayJuun, and Dr. Gray Faulkenberry is the CTO of MayJuun. So if not anything, I mean, they always inspire me because both of them are doctors by day and sometimes by night, and then the rest of the 24 hours, they are technologists and hardcore technologists, I must say. So a warm welcome, John and Gray, to Startup Still. Why don't we kick it off? Maybe with John, you can go first and tell a little bit more about yourself and your journey of how you started off MayJuun.
Yeah, sure. And thanks for the introduction, Anthony. We've gone a long time back, so it's great to have the opportunity to speak here. So I'm John Manning. I'm an emergency medicine physician by training. I teach medical students and residents how to care for patients in one of the level 1 trauma centers in Charlotte, North Carolina, and have done that for almost a decade at this point, getting close to that point. Right before coming down here, like right around that time, I co-founded MayJuun with an interest in building technology solutions that focused on human factors, usability, and just trying to make your life easier from an end user perspective. The kind of short version of it, and we can go in depth if interested, but I used to be a scribe in a medical field in DC. I hand wrote notes helping emergency physicians. Was there when we transitioned from paper to electronic, saw the equivalent of 20 different health systems across med school, residency, fellowship, et cetera, and all with different levels of medical record integration and usability. A lot of them had a lot of usability challenges, and my attempt to give back was in building tech solutions through May that focus on that.
Awesome. Great. Why don't you do the same? Just introduce yourself.
Yeah. Great, and thanks again for having us. I'm excited to be here. I've been looking forward to it, even though I responded late. So I'm Gray Faulkenberry. I'm CTO, trained in internal medicine and pediatrics. I practice as an adult hospitalist, and my other part of my day job is I'm the co-chair of the Global Health Informatics Program at the Children's Hospital of Philadelphia. Although I actually live in Atlanta, that's one of the joys of technology and informatics is that so much of it's virtual. You know, you don't have to be in the place where you practice, which is really nice and allows flexibility. There's a longer story involved, but I got into this from the global health perspective, actually, and looking at how you can sort of leverage technology abroad to improve healthcare.
That is awesome. It's a super worthy cause, and like I've heard from both of you, I mean, it's obviously, even in a country like the US, it is informatics and the amount of manual effort that goes into the work, aside from you guys caring for patients, I mean, is a big part of every doctor's day, right? I mean, and there's so much of others involved in it as well. So let me ask you this. I mean, where did you kind of get the itch to say, okay, man, this is a big problem. We got to do something about it. I mean, who started that? I mean, I'm sure both of you have to think about that vision and believe in it, saying, okay, we can do something to do it. But John, I know you started this, and Gray probably joined later. So why don't you tell the audience about, I mean, where is it that you noticed this? I mean, I know you said you were a scribe maybe there, but tell us more.
Yeah, so it all kind of comes back full circle in when you're just trying to think through like how you can improve and where those options are. You mentioned usability being a big issue for physicians. Christine Sensky from the American Medical Association published on that. There's a thing called pajama time, which is the time you spend at home just charting. and catching up on your documentation, and every specialty has it. It's not fun. It causes burnout. It leads to burnout. So it's everywhere. The specific path that led to MayJuun, interestingly, was as a resident in emergency medicine. I pitched an idea to the first ever emergency medicine hackathon at their national conference, got the grand prize, got a bonus phase prize, and an opportunity to speak at a public health summit in part of the keynote in Illinois. So we built an app that was based on the hackathon idea, wrote it in Java. It's the first time that we'd ever written any sort of code. It was a Java developer friend of mine who had not written anything in Android before, neither had I. He lived a few months away, or a few blocks away. And the better part of my final year of residency training was building this application. All through fellowship, got a lot of opportunities to work with other startups and do a bit of mentoring and working with a group called Matter, the health tech incubator. And time, unfortunately, broke a little bit of the app. Wow. And when we were trying to think through, am I going to do this in Kotlin because Kotlin is new? Am I going to switch over? Am I going to just update this in Java? That was almost exactly the time that Flutter was announced. So December of 2018. The next month, I was in Boston giving a live coding session, handshaking for 5 minutes, showing how you can really make this, because I just fell in love with Flutter. A few months later, it was a big informatics conference at their annual symposium, or their clinical informatics conference. And in 2 hours, introduced Flutter and live coded how to create the conference's app in real time while just talking and writing code. And one of Gray's predecessors, his co-fellow 1 year ahead of him, sat through that conference. There was like 70, 80 people in that 2 hour event. And when he joined that informatics fellowship, a few months later, he was interested in global health and maybe Android, or, trying to build and develop for this. And she looked at him, she was like, well, why don't you just look into Flutter? Mm-hmm. And he started looking into this, and there was a shared Slack channel with a lot of informatics fellows that were going through this new training. And we started collaborating every day over Slack over years, and started building these solutions that would then allow other people that are in and around the health tech space to use the standard for interoperability, FHIR, within Flutter applications. And much of that goes to Gray, and all of the time and effort that was spent in this. I just make apps in Flutter, and I can live code, and I can talk, and just the emergency medicine brain. I can talk and write code at the same time, and that's my thing. But a lot of that underpinning and architecture that's open source and has been used by developers a lot across the world, that goes with many thanks to Gray.
That is awesome, John. So you touched on a lot there, right? I mean, you talked about FHIR, obviously informatics, and Gray, maybe you can wear the CTO hat. I've always wondered, you guys have very little time, yet you found the time to learn a technology like Flutter, decide and pick on it, saying, okay, this is the best choice to move forward with what we're trying to build. Obviously you don't need to be an engineer to learn Flutter and use Flutter anymore. You are perfect examples for that, right? But how did that love for even technology come in to both of you? Obviously you need a spark within you. You need that push within you to say, okay, this is not something that I can outsource to a company and say, build it. I want to do this myself, right? How did you sort of make that choice, Gray, to say, okay, you guys want to be, getting your hands and feet wet with building this whole thing?
So my love of technology and sort of science, I think, and John's too, is not a new phenomenon. We liked it growing up. In college, I was a physics major and I minored in computer science. So I had a little bit of a background, but then I didn't really use it. I went to medical school and was in medical school when EHRs really started coming around and sort of everybody switching over from paper to electronic. And so I saw that transition. And at the time, it was exciting. I was looking forward to it because, again, I like technology. And at the time, it seemed mostly good. The not having to fight for the chart having one chart for a patient and having 8 people trying to look at it, you didn't have to worry about that anymore. Having to walk across or down 15 floors and across campus to write an order in a chart, you could just put it into the computer. So there were some really nice things about it. And then there were a lot of not nice things about it. It was obvious, as John said, the usability was not a sort of forefront in anyone's mind, with the design of these. And any sort of study or survey done on physicians now, you'll see that, that there is burnout. And so you work with that long enough, and it becomes a source of frustration because it really felt like the people who designed it hadn't ever seen a patient, and that was probably true. And you really need to understand the workflow. You need to understand how it feels and what you need and how it should be organized to take care of, a patient. And I think what drove a lot of us into informatics is the feeling that we want to be involved in this. We want to help make this better. This is a skill set that we feel like we have and we can develop and we can actually contribute and sort of change things for the better. So much of medicine is already sort of set in place, and there's so little opportunity to sort of change any of it. But informatics, I think, is different. It is still new. It is still changing. It is a lot of it is sort of set, but a lot of it's not. I think enough of it's not that we can sort of affect that change. And I think that's what's exciting about it, is the feeling that I actually have the ability to hopefully, help medicine and healthcare be provided in a better way through technology. And that was sort of how informatics, I think, came into my life.
Yeah. So if you think of, as an example in medicine of something that's never changed and it will never change, coagulation cascade, which, sure, whatever. Okay. You don't have to know about it. There's a dozen factors. One of them is literally just calcium, and it was named its own factor. Sure. And another one, factor 6, they found out, actually, it was just another version of factor 7. And so there is no factor 6. There isn't one. So it's labeled up to a dozen or 13, but you're missing a whole number. And since we've all learned it this way, I'm sorry, you have to learn it that way too, even though it makes no sense. Yeah. Welcome to healthcare. Here's a chance where we can actually build things that match the workflow that's there. To Gray's point, if you don't see it, if your brain isn't literally into the weeds, and there's one thing to be shadowing somebody who is doing this. There's another where you are putting all of your cognitive effort and load into the care of a person so you don't make those mistakes. And so that, medicine always has mistakes, but so that you minimize that and yet you allow for the right processes and everything to help. Well, if you have a very expert, complex system that's pulling all of your attention away, you're going to get distracted and things will happen, and it's, can lead to harm. If you, what was the book, that was talking about the digital doctor from 10 years ago or 10 to 15 years ago, talks about all the processes of how a 15-year-old child swallowed 38 and a half pills of a single antibiotic and seized, and all of the workflow things as well as the medical issues that were a part of your electronic health record. That was almost like a Swiss cheese effect where everything was perfectly aligned to a point of a nurse in a room with a 15-year-old by himself with mom or dad not nearby as he is individually swallowing almost 40 pills. Yeah. There's a lot to it. So any ways that we can improve that medical perspective, I think, is helpful.
And speaking of a medical perspective, John, I know both of you have touched on what you're trying to make better. But if there's someone who just is a layman, in layman's terms, if you want to explain a before MayJuun and an after May story, of course, using FHIR, which is FHIR for those listening. How do you explain the work that you guys are doing to make this thing better?
So I could take this one. So part of it, I think, is something that we're all familiar with. And again, in no way as a clinician, I think as a patient, you see it. We all go to doctor's appointments or healthcare appointments or therapy appointments where you would like to be able to move records around. You've seen someone else before, you would like to share those records with someone else. And it's always painful. It's always extremely hard. You have to fill out release sheets and they have to often fax them over. The fact that fax comes into conversation at all anymore is ridiculous, but it does in medicine all the time. I regularly get 200 pages of faxes of someone's medical record from another hospital. Trying to take care of it because medical records don't share data very well. And then about not quite 15 years ago now, there was a standard that started being developed called FHIR, Fast Healthcare Interoperability Resources, in order to share it. And again, that's a big deal because just having that information is so important. So the ability to easily share healthcare data is not just a convenience issue, it's a safety issue. If I don't know what medication someone's taking and I give them something that interacts, that obviously can be incredibly dangerous. I don't need to do certain tests if I know that they were just done somewhere else. And so having the ability to more easily share that data from place to place is incredibly important. And I think it helps both from sort of a frustration and a time sort of commitment as well as a pure safety issue. And that's something that, again, we've sort of touched on. As John pointed out, we both sort of lean slightly different directions on this, but again, trying to make electronic records that work better for the people involved. So we want to be able to share data. We want it to work well. We want it to be easy to use. And so I think both the sharing of the data and the usability can't be overstated about sort of how important those aspects are.
Yeah.
So adding to that a little bit, and when you think of FHIR, so FHIR is now the global standard for interoperable communication of healthcare data, period. It's adopted by the US government for large electronic medical records. They have to support at least a core subset of FHIR data that patients can get access to at no cost. And when you're trying to communicate this data, it is miles beyond what was there before the FHIR standard. What kind of happened through all of this? So FHIR-FLI, FHIR with Flutter Library Integration, FLI, were the packages that Gray had developed over the course of his fellowship, which is about 10 million lines of code total, 3 million lines of Dart. A lot of it's auto-generated, but in a way that allows you to use any published version of FHIR that also goes through all its test cases and then directly put this into your Flutter application. And the Android equivalent of this is Open Health Stack by Google. For Flutter, if you're building a Flutter app, you should use the FHIR-FLI packages. So, to Gray's point, so he's a medicine peds trained hospitalist. So he cares for patients when they're admitted to the hospital, adults and children. He practiced in 8 countries, spent a year in Uganda, wrote the textbook on pediatric care in that setting, and has a very high global health focus of trying to help in areas that are very resource limited. My background is emergencies. I care for emergencies. I did EMS things, and a lot of the things that come around me is in emergencies and disasters, and how can we improve in those care settings that are unscheduled and where a lot of people are afraid. Both of them have opportunities to improve in rural areas as well as global. So to your point that you had mentioned earlier, Anthony, of what was our story? Well, we both had a shared interest of building things to help in healthcare from a usability perspective with a mobile first approach, then collaborated on the FHIR-FLI packages, reached out to the Office of the National Coordinator. The actual national coordinator at the time was Don Rucker, who we got through other members of MayJuun. They had connections, and here we are in front of the ONC talking about FHIR-FLI and how cool this is. And they said, look into social health, like social care areas. And so that is where we built screening tools to help with social need in multiple states and multiple languages. And we're still on the Gravity Project's main page as their success story, which is wonderful and cool. But, as clinicians, we're always trying to see how best we can apply this in a way that helps in rural, underserved, and in global areas.
Yeah. So you mentioned emergency medicine. One of the things that always bothers me about, going to a hospital in the US, even if you go to an emergency, is it's never an emergency in an emergency, right? I mean, you'd go with, so much pain and you'd be like, want to be seen immediately. You're invariably waiting for 60 to 90 minutes before you've seen, or at least somebody comes and asks you something, right? I mean, and in a lot of cases, it has got to do with data collection. They are validating it behind the scenes. So, just as a patient myself, or, somebody who I've seen even in the children's hospitals, great, right? I mean, when my daughter was young, I mean, she'd be running very high temperature and you go there, they make you sit for 45 minutes, right? I mean, why? Because they're still collecting data. So in that sort of a, let's say, I mean, you don't want to call it life-threatening, but it's still an emergency. Is there something that, using FHIR and MayJuun, I mean, you can simplify that process to accelerate the time to which, by the time you walk in through that door, a doctor is able to see you at least within 15 minutes or so. I mean, if 60 minutes is too much, at least cut that down by, 75%. If
So yes and no. So I think on the other side of the curtain, so Atrium Health is where I practice, associate professor, and I care for adults and children. And it's patients are not seen in the same order that they arrive. They are seen often by the sickest ones first. So thankfully, you and your family were not that sick. There's an emergency. Of course, we'll address that. But trust me, the very, very near death patients and severe traumas and medical and traumatic resuscitations, they're seen really fast. It's not 60 minutes. And there are workflow tools where you can even register a patient without any information quickly, be it medical or trauma, so that you can give them medications and treat them and get, do an ultrasound or get some x-rays or something at the bedside to help them. All of that stuff has its own workflow. In American medicine that uses the electronic medical record, and the use of MayJuun technology probably isn't as relevant there. If you look in resource limited scenarios, so another example, I helped with some of the hurricane relief efforts in Western North Carolina, where it was multiple groups together, and some of us were using paper and some of us were using another technically medical record that also wasn't really designed by a clinician. And it was clear that there were a lot of opportunities to improve with that. That's a place where we can inject and help, and where we have the skill set and the expertise and the domain knowledge to improve in those settings. And we've had conversations with groups that were interested in our services from there. So from the overarching perspective of, just emergency medicine care, usually it's going to be in the low resource or disaster response or international area where we can improve, rather than the traditional brick and mortar emergency department. But medicine always changes. If we build something and then it expands and then it continues to expand, and that's right up both Gray and my alley of ways that we can improve in areas that also build on the background and expertise that we have.
That's perfect.
And I'll say a slightly different sort of view of it. Again, not sort of the emergent view in terms of how quick we can get you in, but I think that some of the stuff we do can make the time we spend with you more valuable. And I think that, most of the time, the amount of time that we spend with a patient, most of it is collecting data. And very little of it is actually spent talking to a patient. And so I think using technology, including some of the MayJuun, questionnaire data gathering, structured data capture sort of stuff, a lot of that could be done beforehand. And so if you have a 15 or a 20-minute appointment, or, whatever John has available to be able to see you in the emergency room before the next trauma, instead of spending all that time, or the bulk of it, trying to gather all your information, make sure that we have all of your medications correct, that we know all of your history. If that can all be shared or gathered more efficiently ahead of time, then we can sort of review it quickly, and then we can spend more time talking to you. We can spend more time ensuring that we didn't miss anything that's important. We can ensure that you understand the plan. And so the time that we do spend with you can be actually spent with you.
Yeah.
And sort of caring about what the problem is instead of just asking you a whole lot of questions. And so I think there are some ways, even in sort of a traditional setting, where we could be beneficial. That again, I think there's lots of opportunities to sort of improve that.
Yeah, thank you for that. I mean,
The term doctor.
go ahead, John.
Oh, go ahead. The term doctor comes from docere, which means to teach. It is literally your role is to match somebody's health literacy and then help explain and work through that. And the other point from Gray is if you've ever seen, there's a 2012 article in JAMA called "The Cost of Technology" by Toll. And it was a drawing of a 7-year-old in their pediatrician's clinic where, they're smiling, mom's smiling, big sister's holding baby child, like baby sibling, everybody's smiling. Then the doctor is smiling, but has their back turned and is staring at a computer. And this is over 13 years ago when that was done, and it's still relevant today.
Yeah. And again, I think that's, again, to dive back into the technology, I think that's where Flutter is so nice. And actually part of the reason we chose it as the health stack. I was looking at sort of a global perspective, and everything global has to be mobile, right? It has to be at least available. And most EHRs are not. Most of them were never designed to be. And so, we were looking at, well, what's flexible, what can be done, in multiple platforms, multiple devices, and that's sort of what sold me on Flutter. Because as John said, one of my colleagues said, well, she had seen this talk about Flutter, maybe I should look into it. So I did, and I got on Slack and I started working with John. And the punchline to his story was that it was about 2 years later when I realized that the speech my colleague had seen was given by John that then got me into Flutter. So it was. Yeah, it's full circle.
Yeah, full circle indeed. And thanks for sharing the procedure about how the emergency rooms work, right? I mean, I know everybody comes in there and there's nothing more frustrating than waiting, right? So all your anger levels go up, and you see a lot of people walking up to the poor receptionist and saying, I've been here for 90 minutes, why is nobody seeing me? So that part is super helpful. So shifting gears a little bit, John and Gray, obviously you started MayJuun with a vision, right? How much of that have you achieved, and what are the next couple of years looking like for you guys with MayJuun? Either of you can take it.
So I'll say that our vision always shifts forward. We're always working to build new things, better things. Everything we've built in MayJuun has been contracted work for hire to satisfy a specific problem that needed some extra usability flair that was cross-platform by design, and frequently had one group or one solution that didn't match the initial expectations. So a good example of the first thing we built was for an EMS agency that had protocols to help in rural areas that the content was excellent. That was something they built and curated, but the delivery needed help. And so we helped. And, we continue to help and support them for years. We're always building, and we're always doing this in a way that can scale into other solutions and can apply some of the backgrounds and experiences that we have as practicing clinicians and informaticians. And we have other informatics clinicians that are a part of May as well, and in addition to more tech first people as well. I think for us, we're always trying to find that best opportunity where we can have the biggest impact on the broadest scale in a way that pushes things forward in a good way. And I think that's always where we've strived. And so are we there yet? I'll say no. Are we always going down that path? Yes. And it's one opportunity after the next and one solution after the next as we learn and make our code better. And as we provide that service of FHIR-FLI for the global community, in addition to building upon that and harnessing it with the tools that we that we then deploy.
Got it. Gray, you want to add anything?
Yeah, well, I think that a lot of what we've done so far was still sort of foundation building to an extent. It was sort of learning and building out our skills, building out, I mean, some of it was certainly sort of technology, building out the tech stack and that sort of thing. And some of it was also sort of finding where we wanted to be. We've done, a number of different projects in a number of different places, sort of in and sort of slightly out of healthcare, always intertwined. And so I think we've sort of found our niche and sort of where we want to be. And I think that's, again, it's sort of exciting. And a lot of times it's places that other, groups don't want to go. And again, sometimes there's a monetary barrier to it. Whether it's sort of rural areas or low resource settings or disaster relief, one of the ones that again, John brought up earlier. These are all really important to have good health tech stacks for if you're going to actually collect data and be able to show what you're doing, who you're treating. It's important to be able to record all that. It's really hard though. But I think, a lot of that fits what our interests and what our passions are, and our knowledge and our expertise. And so I think we're sort of excited and looking forward to being able to use, who we are and what we want to do at it, even more effectively as we move forward.
That is great to hear, especially the part that you're always kind of looking forward, right? And I try to bring up AI in most of our conversations because, it seems to be affecting everything. And especially, I've heard in healthcare, there's a lot of use cases. John, you started off with scribing. I've heard a number of hospitals using those live scribers sort of thing. But with your vision for MayJuun and kind of looking forward and the impact that AI can make, or the other trend I've been hearing about is, taking the hospital to the home. Right. If there's critically ill patients, you're moving a lot of equipment into the patient's house and still collecting data and things like that. Or there's a lot of, devices that the patients can carry home, but as a doctor, you still want to collect all that information. So looking at some of these new trends, what are your thoughts on, how MayJuun will evolve? Obviously, you would have given that thought. Second part of the question is, how much of AI have you actually tried to bring into the whole tech stack and try to do something with it?
There's a few things from that. So the first one is AI from the perspective of the clinician, and the second is AI from the perspective of the developer. And they're totally different buckets. So let's take the first bucket. So first one, I've given local talks, given talks at AMIA about this, and I've tested this, and I also co-chair our service line innovation and informatics group within Atrium. And we've tested this from the very beginning and with frequency. There is a difference between, so as a scribe, you mentioned this, there's a difference between a good scribe and a bad scribe. And a good scribe speeds you up. A bad scribe has things interjected that gives you almost twice the amount of time that you would be using otherwise. Tech always changes. Even a year ago, there were a lot of bad scribe ambient dictation tools out that a lot of it's improved, even in the last 8 months. And if you want something to look at, there was a AI tech sprint from the VA, the Veterans Administration, that was hosted at the start of this year and then announced early Q2. And if you just search for AI tech sprint within the VA, you can see some of the companies that were well embedded in that perspective. I think ambient dictation is going to have a high opportunity to help clinicians caring for patients, albeit in limited resource settings. That's going to be a challenge still, just because all of these need a lot more cloud services available to them. So that's going to be, your mileage may vary depending on where you practice, but there's definitely opportunity. The other aspect for decision support from the clinician's perspective, I think is great. What used to be called clinical decision support is now being rebranded by the ONC as a decision support instrument, which includes AI and also requires you to have to get past that black box of, where did this algorithm come from? Is this actually a hallucination, or am I where am I getting this recommendation? And I think that guardrail is just as important as the solution itself, because medical hallucinations of artificial intelligence and machine learning programs can cause those same issues that I talked about, where the 15-year-old is swallowing almost 40 pills. We don't want that. And so there's that. The other perspective of building within AI tools as technology specialists and developers, using a model to help you as you're writing code is essentially your own personalized pair programmer, I think is really useful. If you have at least a basic understanding of the tech that you're trying to build in, it's not going to supplant your knowledge and information, and you have to work through some of the suggestions that are high confidence and low accuracy. Otherwise, your code will suffer from that. But there's really a lot of opportunities as you're building to help speed that up, and time has shown us that, as well as from the perspective of the clinician as you're caring for patients at the bedside.
And I think there's some ways to use it that have not been, or are not sort of classic when you think about it, that could end up being really useful. We know, for instance, that most research has to be published in English. It has to be written in a certain form of English. And much of the world doesn't speak English as their first language. And so if you can't write a research paper in the proper prose, your research is not going to be accepted, just even if it's high quality. And so, but having AI help you write a research paper, where your research and your methods are sound, but because you may struggle with English, you can't get it published, that's a barrier to entry that shouldn't be there. And AI might be really helpful to help you with that. One of the ones we were actually looking at was sort of what John was talking about, where you teach people some basic data science and then use AI to help, analyze your data. There's lots of places where they don't have people that can do it themselves, and sort of AI can help with that. And so I certainly think AI has a good role to play. I think you have to be really careful with it. I think that most AI, especially in a healthcare setting, is untested. I think implementing a technology, you should study it. We do with all the rest of the technology. And yet AI, I don't think, is undergoing the same sort of, scrutiny, which, again, I think is going to have some difficulty and some problems that it's going to introduce. It has to be trained on something. Lots of the old healthcare data is not great. And a lot of it's biased. And I think that's the other thing to really be cautious about, is that if you're going to train on it, we know AI tends to amplify sort of biases in data. And so you have to be really cautious, I think, using AI especially for decision making.
The classic example for that was the likelihood of a skin lesion being cancer was increased from the AI algorithms if you had a ruler right next to it, because the images they were trained on, whenever you're measuring the malignant lesion, they all had rulers. And so the ruler was a predictive variable. Yeah. That's not right.
Yeah, I heard the exact same story. I mean, I did a AI course at Stanford this summer, and that's the exact same story that professor told us about. So I do understand. I mean, you got to be super careful, but there are some merits, right? I mean, if you test it to Grace's point and put it through the rigor of going through all that unbiased data and things like that, I mean, there is some benefit to it. So switching gears a little bit, how much of adoption have you seen here? And I know for a fact that, I mean, you've tried to take this outside of the Americas as well, to some of the countries. Who is using, whether it's FHIR-FLI or the overall stack in general, who is using it today?
So last we checked, again, there were certain developers that were implementing it in Brazil, Colombia, Mexico, Germany, Italy, India, and Nigeria.
Canada
as well.
Awesome.
Right.
That's great.
I'll say that's good adoption from what we've developed over the time. I always think that's reassuring.
And speaking of adoption, John and Gray, I mean, I'm assuming all of this is open source as well. Everything you do, you put it out there for people to contribute, or anything people should know about?
Everything that is the baseline package that we want to help everybody is open source. Okay. So FHIR-FLI is open source. Okay. The EMS project that I talked about, that's open source. Some of the things that we've built were closed. Some have different permissive licenses that allow other people to learn from, but not necessarily directly compete with. So like functional source, if you've heard about those. But realistically, our goal is we always want to move the needle forward. We're not trying to train up other people that then immediately directly compete with us. But for FHIR-FLI, we want this to be useful for everyone. That is a core package that everybody needs to have, and that will always be open source, through the duration that we're supporting, and it needs to be like that just indefinitely.
And again, we want it to be, Google's Open Health Stack we brought up before, and the Android SDK is used in a number of standards now. It's actually the WHO is creating smart guidelines that's going to be used sort of around the world, which is based on Open Health Stack and Android SDK. And again, we're not competing with them. There's no reason to. There's lots of work, but we want sort of a parallel option because, again, we see the value in Flutter and being able to create something that could then be used and implemented, again, sort of based on WHO guidelines. And that's, again, the sort of thing where we don't want to keep it to ourselves. We want to share it. We want anyone who's interested or available or wants to try it or work with it, develop with it. We want to encourage that.
Perfect. Thank you so much. Anything else that I've not asked about MayJuun that you want to get out there, the community to know?
Say, if anybody is interested for us, certainly go to MayJuun.com. If you're interested in FHIR-FLI, there's FHIR-FLI.dev. There's a Slack that people can join where you can collaborate with others across the globe that are building solutions here. We're pretty easily approachable. We're always happy to collaborate with others that are deeply invested and interested in this space, and hopefully making things better for patients and families and clinicians as we go from 1 month to the next, 1 year to the next. We're always happy to work together and to collaborate.
Yeah, agreed. Well said, John.
So with that, Gray and John, always a pleasure speaking to you both. I'm always cheering for you guys and talking about MayJuun to whomever I think is relevant. So wish you guys the best.
We appreciate it.
And anything, I'll be sure to publish all the details about MayJuun, all your repos and your Slack and everything on the YouTube channel.
Great.
So I'm sure there'll be a bunch of questions I'm sure you can answer. But thanks so much for taking the time amidst your busy schedules. Lovely to speak to both of you. And I learned a lot. Hopefully everyone listening in and tuning in learns a bunch as well. Thank you so much.
Yeah.
Thanks, Anthony.
Thank you for having us.
Pleasure.
It was fun.
Thank you.